Improving the inpatient management for diabetes mellitus at Griffin Hospital through teaching sessions to the residents. Goals of this project is to standardize inpatient management of diabetes mellitus, in line with the current standard of care. Main objectives to learn are: total daily dose calculation, how to distribute for long and short-acting insulin, how to customize ISS based on bolus plus scale based on insulin sensitivity, how to put order in the system in sequential order, how to manage DM patient who is NPO, how to transition from home insulin to hospital insulin regimen. General rules. A patient with type 1 DM will always need exogenous basal insulin, even if NPO. Failure to give will lead to DKA. Once insulin therapy is started, a target glucose range of 140 to 180 mg/dl is recommended for most critically ill and non-critically ill patient. Reasonable glycemic goal to avoid hypoglycemia is to achieve fasting BG no lower than 90 to 100 mg/dl. Sliding scale insulin regimen alone is strongly discouraged. For type 1 diabetes mellitus, continue insulin 75 to 100% of total daily insulin used at home. If on an insulin pump, always consult endo. Consider endo consult for patients taking insulin total daily dose more than 1 unit per kilogram per day. For type 2 diabetes mellitus, discontinue all oral and non-insulin injectable diabetes medications upon hospital admission. Start basal bolus insulin if on 2 occasions with proven hyperglycemia more than 180 mg per deciliter. Physiologic insulin regimen. All patients have basal, nutritional and correctional requirements. Basal, long-acting insulin needed even when the patient is not eating, to control gluconeogenesis. Use insulin levemir. Nutritional, insulin to cover carbohydrate intake from food, dextrose from fluids, tube feeds and TPN. Use rapid-acting, aspart, or short-acting, regular insulin. Correctional, insulin given to bring a high glucose level down to a target range. Step 1 is to determine the total daily dose by using the formula 0.5 units per kilogram per day. Step 2 is to determine basal and bolus insulin. The basal dose is equal to 50% of the total daily dose. We usually use insulin levemir once or twice daily. Bolus dose or nutritional dose is 50% of the total daily dose divided into 3. We use insulin aspart before meals 3 times a day. Step 3. Add correctional insulin for hyperglycemia. Use a sliding scale for correction based on pre-meal blood glucose. Let's calculate insulin dose of a patient weighing 80 kg with normal renal function. Step 1 is to calculate total daily dose, which is obtained by multiplying weight with 0.5, so in this case 80 multiplied by 0.5 is 40 units. Step 2 is to split total daily dose to basal and bolus insulin. Basal insulin, long-acting like glargine, detamir, or degludec. 50% of total daily dose 40 divided by 2 equals 20 units per day. Bolus insulin, rapid-acting like aspart, lispro, glulicine, before meals. 50% of total daily dose is divided among 3 meals, so 20 units are divided among 3 meals. Per meal dose is 20 divided by 3, 7 units per meal. Correctional insulin. Use the sliding scale before meals and at bedtime. Calculate the insulin dose for this patient. 56-year-old woman with type 2 diabetes mellitus who is admitted with stroke. Weight, 100 kg. Home medical regimen, glipizide 10 mg daily, metformin 1000 mg twice daily and 20 units of NPEH-QHS. A recent A1C is 10%, point of care glucose in ED is 240 mg per dl. The total daily insulin dose for this patient is 0.5 units per kilogram times 100 kg equals 50 units per day. Basal insulin is 50% of total daily dose. 25 units glargine QHS. Prandial insulin is 50% of total daily dose divided among 3 meals. 8 units rapid-acting insulin, for example, lispro/aspart, with each meal. For correctional insulin, add sliding scale insulin with meals and at bedtime. Next cases. 64-year-old male with past medical history of type 2 diabetes, peripheral neuropathy, peripheral vascular disease, presence to the ED because of worsening pain, erythema, and drainage from his right foot for the past few days. Admitted for sepsis, and he will require surgical debridement in the morning. Height, 5 feet 10 in. Weight, 251 pounds, 114 kilograms. He is on Jardiance 10 mg daily and metformin 1000 mg twice daily for diabetes at home. As this patient's weight is 114 kg. So the total daily insulin dose is estimated at 0.5 units per kilogram per day equals 57 units per day if eating normally. So the basal dose is 28 units. However, the patient is not eating. To reduce hypoglycemia risk, use 70% of the basal dose while NPO. 28 times 0.7 equals 20 units of glargine. Insulin regimen while NPO. Insulin glargine 20 units once daily. Regular insulin every 6 hours per sliding scale. How to manage this patient's diabetes in the hospital setting. Age 67-year-old male with type 2 diabetes mellitus for 16 years and with CKD stage 3B, weighs 70 kilograms. He follows a healthy diet and takes his medications as prescribed. The 1C 7.6%. Current medications. Glargine 40 units daily, aspart 10 units with meals plus insulin sliding scale. Continue basal insulin, glargine. Patient already on glargine 40 units per day. You can continue it if clinically stable and eating. If NPO or reduced intake, consider reducing dose by 20 to 30% to avoid hypoglycemia. 2. Mealtime insulin, aspart. If the patient is eating meals, continue aspart with meals, for example, 10 units or adjust based on carb intake or BG. 3. Insulin sliding scale, ISS. Continue correctional insulin, aspart, with meals depending on intake. Use a moderate sliding scale given CKD to avoid aggressive correction to reduce hypoglycemia risk.